afternoon, good morning, and good evening. Welcome to the joint IFSO BJS Academy Virtual Journal Club on the International Consensus Position Statement on the role of obesity management medications in the context of metabolic bariatric surgery, the expert guideline that was published by IFSO last year. It's an honor and a privilege to co-chair this session with Professor Wendy Brown, who's a bariatric surgeon in Melbourne, Australia, and the Secretary Treasurer of IFSO. And I'm Sarah Suleiman. I'm an endocrinologist in Imperial College Abu Dhabi and the President of IFSO Integrated Health. I'll hand over to my co-chair, Wendy.
Thank you very much, Sarah, and thank you all very much for joining us. As Sarah says, it's a real privilege to be here today, and we're really very lucky to have Carol presenting for us. So Anna Carolina Barista Dantas, who is an assistant professor of surgery at the Department of Surgery at the Federal University of Rio Grande do Norte in Brazil, and I apologise for my pronunciation. She's also the Latin American representative of Young IFSO and is a member of Young BJS. So Carol is a real rising star in metabolic bariatric surgery, and she's going to present to us today on this really important paper that I think is probably covering the hottest topic at the moment in obesity care. So with no further ado, we'll hand over to the presentation, and I just encourage you to make note of any questions that you might like to ask towards the end, at the end of the presentation, as we'll have a really good discussion afterwards, and you can put those questions in the chat. So thank you very much.
Hello everyone, it's a pleasure to participate with all of you in the first IFSO BJS Academy Virtual Journal Club. My name is Ana Carolina, I'm a bariatric surgeon in Brazil and the Young IFSO Latin American chapter representative. We'll discuss today a paper published in BJS 1 year ago in the end of 2024, an international consensus position statement on the role of obesity management medications in the context of metabolic and bariatric surgery. This is an expert guideline by IFSO. We all know that metabolic and bariatric surgery is the most effective long-term treatment for obesity, but pharmacotherapy, modern pharmacotherapy with intestinal hormonal analogs, has shown good results in short and midterm follow-up. However, high-level evidence on its use before and after bariatric surgery is still scarce. So considering all this, the aim of this study was to provide an evidence-based recommendations for using these medications before and after metabolic and bariatric surgery through a Delphi process with a multidisciplinary team of international experts on obesity treatment. To better understand this manuscript, we must remember definitions and nomenclatures that were used. Clinical obesity as excess adiposity with signs and symptoms that impacted a patient's life. MBS outcomes were previously defined in another IFSO statement using the nomenclature of suboptimal initial clinical response and recurrent weight gain. And modern OMMs were second-generation intestinal hormonal analogs. These were the partner organizations that participated on this Delphi process along with IFSO. So they joined 40 international academic authorities to participate in this process. All the participants received a review of evidence based on a systematic review that included preoperative and postoperative use of OMMs, the class of drugs employed, the impact on weight and obesity-related complications, and the effectiveness and complications of using OMMs before and after bariatric surgery. This Delphi process had two steps, one initial online step in March 2024, and a second 2-day in-person meeting in April 2024 where the participants had several classes to discuss, and then they started another round of voting. A plus was considered if it achieved 100% consensus, grade A between 90 and 99%, grade B between 80 and 89%, grade C between 70 and 79, grade D between 66 and 69, and less than 66, it failed consensus. This is mostly used in Delphi process. We have 3 tables with many statements that were discussed in this research. You can read them on the original manuscript, but I want to highlight some that are important so we can further discuss along with the other participants. This table 1 is focused on common understanding of obesity, the benefits of different extents of weight loss, and the use of OMMs before MBS. Most statements had grade A plus with 100% consensus, like clinical obesity is a disease that requires treatment. Patients should be informed of the risks and benefits of evidence-based treatment, and other important statements on obesity and treatment itself. But I want to highlight the last statement. In general, preoperative treatment with OMMs should be discontinued before MBS to minimize perioperative risks. This had 94% agreement, and although we can further talk about this in the discussion, I want to highlight that it included modern OMM with the new analogs, but also other medications that are used for obesity treatment. So really there is different approaches to timing of discontinuation of medication before surgery. So maybe this would justify the difference in consensus agreement. The second table is focused on the use of OMMs after MBS. So also most of the statements had 100% consensus with A plus grade, like treatments with OMMs after MBS should generally be withheld until the achievement of a weight plateau, unless there is a compelling clinical need for early initiation. This was one of the most important topics discussed in this article. We'll also further talk about this. But the other statements also highlight the impact on reducing adverse cardiovascular events, on reducing chronic kidney disease, but it's also important to highlight this was in the light of new publications and ongoing evidence on the use of OMMs after MBS. Also, another part of the second table on OMMs after MBS, I think we must highlight this statement 16. In all the Delphi process, it was the one that had the lowest consensus percentage, 74%. So it was grade C. On the benefit of endoscopic therapies for obesity can be enhanced by combination with OMMs. This is actually highly discussed in the literature. It has low quality evidence. We also must consider the different backgrounds of the team that was voting in this Delphi process. So they were clinicians and surgeons, not always focused on endoscopic therapies. So this is an important topic of disagreement in this manuscript. Also, another important topic here is the statement 18. In patients with suboptimal initial clinical response or recurrent weight gain after MBS, different options of treatment, including OMMs, endoscopic therapies, and revisional and conversion surgery, can be considered. We'll later go back to this on the discussion. The table 3 of this Delphi process was focused on future perspective. Also, a lot of statements with 100% agreement, focused on we don't know the long-term efficacy of the medications, endpoints of future clinical trials should consider these new interventions. But I would like to highlight here the statement 25. For patients with recurrent weight gain, treatment with available OMMs should be considered before revisional surgery. Also, the timing of adjunct therapy and the timing of revisional surgery was deeply discussed by the team of participants, was deeply discussed in this article, and this one held 92% of consensus in this table 3. Again, more on table 3 on future perspectives, most with 100% consensus, like study on cost effectiveness of the association with modern medications and MBS are essential to determine the role of preparative and postoperative OMMs, and other topics you can read more on the manuscript, the complete manuscript. On the discussion of this article, they highlight the main statements that had grade A or grade A+. OMMs after MBS result in weight loss that is similar to that achieved for non-surgical patients. This has already many publications, many important evidence on this kind of results, even after this IFSO statement in the last year of 2025. OMMs should be considered for treating a suboptimal initial clinical response or recurrent weight gain after MBS. After surgery, OMMs should be withheld until the achievement of a weight plateau, and also that medication should be considered before revisional surgery. As we talked before, one of the most discussed statements were the timing for starting OMMs after MBS. Generally, the participants and the evidence they used say they should withheld until weight plateau, but some patients may benefit from early adjunct OMMs. The paper does not focus on which kind of patients are these, and we believe we can discuss this in this webinar. And of course, research is needed to identify predictors of who are going to be these patients. Also, there was a lot of agreement on adjunctive OMMs for suboptimal initial clinical response and recurrent weight gain, as we have shown on the tables. And again, highly discussed topic on revisional surgery. We know some surgeons like to go straight to revisional surgery, but this Delphi process, these specialists agree that modern OMMs and endoscopic therapies that are less invasive should be offered before revisional surgery, considering revisional surgery can be a complex procedure with a higher risk of complication for our patients. Again, I would like to thank IFSO and BJS Academy for the opportunity, and we go now to the discussion with the other participants. Thank you again.
Thank you very much, Carol, for a very clear presentation. I wonder if we can open the floor to questions. Please type the questions in and we'll try and handle them. So whilst they're doing that, I wonder if we can ask you, Wendy and myself can ask you a couple of questions. So you alluded to the fact that the paper didn't really say which patients at what point to start obesity management medications. Do you have any thoughts on that?
I think this is the very hot topic on our current practice now, but usually we wait to plateau around 1 and a half after bariatric surgery. But with prediction models, we can see in our practice that some patients start to lose less weight around 6 months. So I'm starting to think of beginning OMMs at this point, around 6 months, if the patient didn't had diabetes remission or the adequate weight loss for that time point. So I'm starting to think earlier than plateau.
Yeah, I agree. I mean, we know there's lots of studies that show us that there is a cohort of people that even at 3 months, if their weight loss trajectory is not as we would expect, that unfortunately they're not going to get the optimal weight loss or health response that they were hoping for from their MBS. So I wonder why we would sort of torture them to wait until they are a year down the track and haven't lost enough weight. But there's another part of me that wonders, is this a cohort of people that just don't respond to obesity treatments? And, I guess the question is, how do we know if they're going to be a responder? Are we going to make them feel even worse if we put them on a treatment that, again, doesn't work? What sort of studies do you reckon we should be doing, Carol, to sort of answer those type of questions?
Of course, in the best, excellent situation, we would need a randomized study. But how can we select this kind of patient in our real life? We would have to consider age, because now we have a lot of elderly patients and we know they lose weight in a different speed. We also would have to consider menopause woman, because we know that impacts also the amount of weight loss. And of course, the technical procedure. We couldn't compare patients who did sleeve with other techniques. So in the best case scenario, I would think we should do very, very similar patient selection, for example, sleeve procedures, younger patients, and choose a point. They lost less than 20% of total weight loss after 6 months, so we could try something like a medication. I don't know, maybe just popped up this idea now. What you think, Sarah and Wendy, in your
So
practice?
a question to Wendy. Do you think that kind of study could arise out of MBS QUIP, where you could select the categories? And
I think it could be a registry-based study. And a lot of countries now have very mature registries, and maybe in MBS QUIP, I don't think follows their patients up for quite
sure.
so long, but some of the other national registries, like the Swedish registry, our Australia and Aotearoa New Zealand registry, the Dutch, Michigan, a few others. I do think there would be an opportunity that you could use in registry, find people that are define what you see as being a suboptimal response or a clinically important time point, and then randomize within the registry. I think there's some really exciting sort of pragmatic real-world trials that we could be thinking about if we all work together on it. I think that's something these medications have really shown us, is if we can work together, we can come up with much better solutions for our patients, can't we? It's like cancer treatment's so rare as a surgeon that I would just do an operation for cancer these days. We'd always be working with the immunotherapy, chemotherapy, radiotherapy, and it's kind of exciting that we now have these treatments that we can actually be offering. And I think it's going to be a real thing that a lot of our patients coming to surgery will have tried medicine before they come to a bariatric operation. And I was kind of interested, I guess the experts met in 2024, and they were saying that you need to stop the medication prior to surgery. Again, I'm not sure that I agree with that. I know the latest anesthesiology guidelines from most countries now suggest it's safe to continue, but maybe do a fluid fast. And if I'm really honest, for years I've been operating on people on GLP-1s for diabetes and never really thought about the risk of aspiration any more than I do any other medication. And there's a real risk of stopping the medications because people often gain weight reasonably rapidly. I don't know, Sarah, in your practice, do you make people stop medication before surgery?
So I agree 100%. Many of our patients don't really need to stop. And if we do stop, we often just omit the one dose before the operation. Most of the time, we've got very expert anaesthetists. It's a non-issue.
Yeah,
I think this is a very complicated situation because, as Wendy said, the anesthesiologists, they ask us like, here in Brazil, they're very conservative. They ask us to stop 3 weeks before surgery. So 3 weeks for a patient that has diabetes or is losing weight to prepare for the procedure is a long time. But we also know the risk of aspiration. And this is such a hot topic now that every week we have new evidence. So like 2 weeks ago, there was a randomized study that interrupted the medication 7 days before and another group that didn't interrupt. And they had greater gastric content, the group that didn't interrupt. So it's very up to date now. I think 1 week is a good amount of time, and we would not fight with the anesthesiologist for that. But 1 month, for example, of more conservative, it's too long for our patients.
I agree. And you don't want people's diabetes unstable. And gosh, we put them on very low calorie diets usually for a couple of weeks before the surgery to ensure that we shrink their livers and reduce their visceral adiposity. So you don't want them in that rapid weak regain phase in that early stage. So I think a more pragmatic approach, and if they're on a liquid VLCD prior to surgery anyway, the stomachs are often very empty the morning of surgery anyway. It's something that I know that we do debate, but I think it's something that we really have to get our heads around, because I think in time it's going to be rare that we meet a patient for bariatric surgery who hasn't at least tried medication. Although I have to admit, in my country, the cost of medication can be prohibitive. And in fact, the cost effectiveness for medication isn't quite as good as surgery, potentially at the moment. What's it like in Brazil and Abu Dhabi? Is medication still quite expensive?
Yes, in Brazil, it's quite expensive, and we don't have access to medication in public health system, only out of pocket. But the problem here in Brazil is with the um, irregular medication, not it's not even compound. It's just like from other neighbor countries, and we don't know if they even are the real medications, but there's a lot of advertisement from Paraguay, for example, and people buy because they're cheaper, but we really don't know what's inside. So it's very difficult to have real data. The concern now in Brazil, it's like with health vigilance and safety, because there's a lot of adverse events from this medication, but they're not the real medication. So we don't know which kind of symptoms the patients that are on the uh, uh, regular medications are having.
Yeah, and similarly in Abu Dhabi, they are expensive medications. We're lucky enough, though, to have a fantastic public service for at least some of our, sorry, my office has decided to go dark. For some of, or a group of people who have a certain insurance, where we can give anti-obesity medications or obesity management medications, providing they've got complications of obesity as well, or a body mass index of over 40. So we have a very similar standard to metabolic bariatric surgery. One of the interesting things on this paper that we didn't really discuss very much is that there was a unanimous agreement that actually the medications are safe, and that even following bariatric surgery, they work well. So one of the things we were concerned about was, will there be a drop-off? Will they have less effect? Now, that doesn't seem to be an issue, and therefore, particularly for people who do not respond so well, it seems a very reasonable direction to take.
We did a small randomized controlled trial that was published last year where we looked at people who'd had gastric bands or sleeves, and overall people did lose more weight, and we were using an earlier generation of GLP-1. But we actually interestingly found that most of we let the patients self-dose and self-escalate, and most of them never really got to the recommended dose. It wasn't an expected finding. We didn't power around that finding. We just expected everyone would get to the recommended dose. But in fact, most people were using a slightly lower dose. And I noticed in the chat, one of the participants, Durade, was saying that they use 2.5 milligrams of one of the GLP-1s in his patients after 6 months if they're below trajectory, which again is quite a small dose of tirzepatide. Have you noticed in practice that, and I know this is an off-label discussion, but I am finding when I'm adding medications in that patients don't necessarily need the full dose, which does help with the cost a little bit too, as well as the side effects. Have you had the similar experience?
Yes, I think I had a similar experience of patients who starting with a smaller dose, and they even don't take weekly because they don't feel the need to, like you said, they're self-dosing, and I think they tolerate well compared to patients who didn't have bariatric surgery, and sometimes even have less side effects.
Yeah,
And similarly,
and I think.
Sorry, please go ahead.
No,
I was
you.
going to say, it's not dissimilar to many other surgical specialties where debulking makes the body more sensitive to treatment. It's just a thought, it's a hypothesis, nothing that we've published data on one of the GLP-1 agonists as well, retrospective data on a large database, looking at response to tirzepatide, and basically about 20% of the participants, it was about 1,800 people, and 20% had had prior metabolic and bariatric surgery, and their response was actually better than those who had not had. It's purely speculative, but just to put it out there.
The other thing I thought of is it could be different pathways that they're,
Absolutely.
targeting, and because I think obesity is the it's the ultimate multifactorial disease, isn't it? And if there was only one pathway, we would have found a cure by now, I think. So I wonder about that. And the fact that, I know gastric bands are not sort of in fashion around the world anymore, but we have a large cohort in Australia. We did a lot of these over the years, but we could get people back onto quite a good trajectory combining the band with a GLP-1. That makes me wonder about the endoscopic treatments, which was one of the things you highlighted, Carol, that maybe if you can combine them for a cohort of patients who are not keen to have part of their stomach removed or their bowel rerouted, that may be more appealing to have something like an endoscopic treatment that's potentially reversible combined with a medication. I think it's exciting to think that we can broaden the range of what we're offering, because surgery alone has only ever really reached about 1% of the potentially available market, or potentially eligible patients. So I don't know. I don't know enough about endoscopic treatments. As Carol said, I don't do them, but has anyone seen them being combined? We don't have a lot available in Australia, unfortunately.
As I mentioned in the presentation, I think one of the reasons for the high disagreement rate is because we're not really used to endoscopic therapy. When we speak to an audience of endoscopists, they're very enthusiastic and they have a lot of experience. But when we compare to overall obesity treatment like medications and bariatric surgery, they have more limited evidence. Smaller group of patients in the study, very limited BMI or clinical complications. So it's different. It's difficult to bring this data to the real world and to compare with more severe patients. I think that is the greatest limitation of endoscopic treatment. Also, it's very expensive. In most countries, it's more expensive than surgery and then medication. So we would have a very expensive treatment option. I don't have a lot of expertise in that area also.
It's not part of the standards of care in Abu Dhabi either. So I'm sorry, I can't add much to that discussion.
No.
We've got a very quiet audience. Please, can you ask some questions so we can take different directions?
I think one of the questions that occurred to me is, we talk about suboptimal response, but it's starting, I guess, well, I know we've got definitions of what a suboptimal weight loss response might be, but I sometimes am starting to think it wonders from whose shoes you're sitting in when you make that assessment, because from a patient's point of view, it might be a suboptimal response because of a number, but it might also be because they haven't achieved a health aim they wanted to do, or some other sort of life target. And I just wonder, now that we've got more treatments available, and it's not just revisional metabolic bariatric surgery, which we all know is much riskier, is it time to reframe what suboptimal means? I don't know, that's a bit philosophical, I guess, but it's a bit like, I don't know, Sarah, if you think about the life cycle of a person, we know there's certain times in your life that you're more likely to gain weight, like if you have a baby and don't lose the weight between babies, or when a man finishes university and gives up sport, they're more likely to gain weight. Women in the perimenopause. I just wonder in the future if we preempt those periods and offer people treatments earlier, either metabolic bariatric surgery if delivered safely, or OMM, or a combination. I don't know. Is that a bit too out there?
It's an excellent comment. And you're right, we need to be far more contextual, because obesity is a lifelong disease, but we know that there are precipitants, there are harder times for people. And again, the beauty of having different options comes in, because perhaps obesity management medications may have a role to play then, sort of trying to manage the difficult times with bariatric surgery as the mainstay when people require them, or even following metabolic bariatric surgery, knowing that someone perhaps is going through a difficult time, having lost someone, or having had 3 babies in a row, or just being able to say that there are options. It's not your fault, and there are options that we can support you with. I think one of the difficulties we have is not just the suboptimal weight loss, but the recurrent weight gain as well, which is quite disheartening for some patients. So I think that the silver lining from this story is that there's no one size fits all, but there are lots of sizes that can work together.
Yes,
Yeah.
I agree. And those outcomes of total weight loss, they're very good for research and to compare our treatments. But we should consider more patient outcomes, like we use for quality of life, the patient reported outcome measures, the weight they want to see, the weight they hope to achieve should be considered as a prom, for example. we consider quality of life and pain, and as you see yourself in the mirror, but prompts don't have the weight the patient wishes to have or the moment in life they're living. It could also be a way to have a numeric comparison for that even.
It's a bit like that concept of treat to target. And I must admit, it's something I'm still trying to get my head around it. I know in endocrinology, and please correct me if I'm wrong, Sarah, you might treat to a target of a hemoglobin A1C that, brings people down to a lower risk. And I guess I'm wondering, those targets in obesity are much harder to define because as you both highlighting, it can be health, it can be well-being, it can be an actual number on a scale. Is this something that we should be working together as a profession to try to work out what those targets should be?
So that's a fantastic question. And I agree. One of the problems with trying to get different stakeholders to take obesity seriously is we don't have a target. But the target, I think, has to be much more than just a single target, as Carol suggested. One of the more straightforward targets that has been proposed is the waist to height ratio, because it seems to be fairly well associated, at least with cardiovascular risk, with a ratio of less than 0.5 being healthy and a ratio above 0.6 being unhealthy, needing treatment, and then between them, somewhere in between. But again, just like Carol says, that's not terribly meaningful if my main problem is my knees and I still can't walk. Thank you very much. I think we just need to be slightly broader in our thoughts to try and amalgamate many things into a score, perhaps an application, something that the patients can actually use themselves to track their health as they go along, to show that we are succeeding. And I think overall we are succeeding. Being in obesity medicine for 15 years, it was a very hard space to be in. But I think partly thanks very much to metabolic bariatric surgery, which not only treats 1% of people who need it, but actually has shown the way. It's shown that managing to lose weight does treat cardiovascular disease, does treat fertility issues, does treat many, many things. And I think there's still an issue with increasing capacity because there are a group of people who will benefit from metabolic bariatric surgery and at the moment don't have access. But there are also medications that are catching up to try and help with perhaps people with lower stages of obesity rather than BMI alone. So there's a couple of questions. One of them is about the cost of oral GLP-1 agonists. So this year, 2 oral GLP-1 agonists have been licensed for obesity treatment, semaglutide or the Wegovy pill, and orforglipirone, which is a slightly different one. And just to compare them, semaglutide is a peptide and therefore needs to be taken on an empty stomach. It costs about 800 dirhams per month, which is just $200 and something per month, US dollars. Orforglipirone is a non-peptide, so it can be taken with food, and the side effects are very similar. The weight loss is probably slightly better with the Wegovy pill, about 17%. With orforglipirone, it's about 11%. And the starting dose of orforglipirone is only just a little bit cheaper. It's about $200 just. But as the doses go up, a bit like Wegovy, the cost goes up to the maximum dose being about 1,600 dirhams, which is about, my math isn't great, but it's $450 US for the highest dose. So actually not dissimilar to Mounjaro. Now the expected weight loss is about 11%, just to put things into context. There's another question. So I'm going to hand this over to my co-chair in the interest of sharing. So it's a question from Melody Moorhead, who says, thank you for your expertise. How do you consider best educating the public to the value of metabolic bariatric surgery with the availability of weight loss medication options, given magical thinking and the magical pill. I'm happy to take this as well, but do go ahead, Wendy, first.
I think that's a great question. Thank you, Melody. And I think we are going through a golden phase with our medications, where it's sort of the wonder drugs at the moment. They're good for everything and everyone wants them. But we've seen this before with other obesity treatments, and then the tide starts to turn, and then there starts to be a bit more of a rebalancing and a bit more of reality. I think what the great thing about medications is that it's very accessible. So lots of people who can afford them or who can get access to them can try them, and they lose a lot of weight and they feel great on them. But then they start thinking, do I want to keep feeling like this, but do I still want to take a tablet for the rest of my life? And so it actually opens up conversations with patients that perhaps they weren't open to before, where you can say to them, well, weight loss has been great for your health. Treating your obesity has helped treat your arthritis. It's helped treat your diabetes. It's helped treat your infertility, whatever it might be. And, I think we're going to start to see a resurgence in metabolic bariatric surgery, where people will be saying, well, I want those effects, but I don't necessarily want to take a tablet for the rest of my life or have an injection for the rest of my life. And also some of the side effects are potentially, not something that people want to live with forever. Say constipation, for example, some of my patients really complain about, or the nausea. So I think I see these drugs as a really positive thing. And I think I acknowledge that at the moment we're seeing a dip in the number of metabolic bariatric surgeries around the world. But I suspect that's going to be a temporary thing, because we're introducing people to the power of weight loss and the importance of weight loss for health. And it will make those conversations about metabolic bariatric surgery ultimately better, I think, and probably a bit more responsible as well, because you give people a bit more context. But maybe I'm being overly optimistic. I don't know, Sarah.
No, I tend to agree. I think the more people who have contact with a physician, the more people who will be appropriately referred for metabolic bariatric surgery. So I think obesity medications, in a way, are opening the door for us to see more patients. There are undoubtedly people who do not respond, the non-responders, even to the best medications we have these days. And that's about 5% of people. And even if it was just that 5% who were referred appropriately, that will create a huge workflow. I think a lot of people have been thinking about obesity. A lot of people living with obesity have been thinking about obesity, but not doing very much about it, and therefore have not had access to care because they just have never presented. And as you rightly say, it might be a door in. I think it's a two-way street. Those of us who've been working in obesity understand that metabolic bariatric surgery at the moment is not only more cost effective, but actually is the most powerful treatment for obesity today. I think a lot of the negative publicity has been driven by people who have not seen people with severe obesity, with sleep apnea, with things that alter their life. And a lot of people, just to take the discussion slightly further, some people worry about this being the end of metabolic bariatric surgery, perhaps such as PPIs with duodenal ulcers. However, my view is this is very much more like cardiothoracic surgery, where there are medications that improve cardiac health. And that just means that metabolic bariatric surgeons are going to be far more experienced. They'll be dealing with people who are perhaps at later stages, where they are technically much, much better. And it's a very safe operation, but I think the volumes will go up rather than down. But the complexity of patients who will be getting it will be more complex in 5 or 10 years' time. Just my opinion.
I think the medications also make people understand that obesity is a disease. It's not a moral failing. It's, you used to go to the doctor and say, I would like to lose weight, and they'll say, well, eat less and exercise more. Well, okay, everyone's tried that. But now that there's a medication, it's emphasizing this is a disease and we do need to take it seriously. And we do. And obviously those of us who've worked in obesity for a long time have taken it seriously for a long time. But I think it's helping to break down some of the barriers and some of the stigma around people being brave enough to come and seek proper care for the disease of obesity.
That what I was going to add. I think as the question came, best asking the best educating, how to best educate the public. I think we see a lot of fighting in social media regarding medications versus bariatric surgery, which is the best treatment, which one is more expensive, side effects, etc. But I think we should focus on educating about obesity. If people, the more
Absolutely.
people understand that obesity is a disease and that it has multiple mechanisms and that it changes the response throughout your life, and there are options for treatment, not only for the general public, the patients, but now working in a university hospital, I talk to medical students, to residents, to colleagues from other specialties, and I think doctors from other specialties, especially clinical, like cardiologists, nephrologists, hepatologists, they are seeing obesity as a disease and referring more severe patients to surgery. As Sarah commented, we are having more and more severe patients coming to surgery because surgery is safer now. And they see that if we don't treat obesity as a disease, we will not improve the other complications and the other diseases they are taking care of.
Absolutely. And, you know, and I really do think having effective medical treatments was the missing link in a lot of those pathways because, rightly, people were nervous about sending their patients for surgery, but now we have 20 years of really good data showing the efficacy and the safety of metabolic bariatric surgery, not just as a weight reduction tool, but as a life-improving tool, a health-giving tool. And we now have this, but people say, well, they don't need to lose that much weight to achieve those things. But now we've got that sort of entree with the medication and the new medications that are coming. Some of them sound like they're going to be offering, even more weight loss. And I just think that's a good thing. In my country, 30% of the population live with obesity, and it's higher in other countries. Now, not every person living with obesity has clinical obesity, but a significant proportion of them would benefit from some weight loss. So the more treatments we've got is the better. And I think we should all be playing nicely together. It's a bit like when bariatric surgeons sometimes, debate my operation's better than your operation. I would kind of say, well, that's okay for an internal debate, but actually the message is that all metabolic bariatric surgery is safe, it's effective, and that people who are brave enough to take that sort of treatment pathway can usually expect to have a really major improvement in their health and their quality of life with the weight loss that's induced. So we shouldn't be arguing, I guess is what I'm saying.
We're not. I think we're not. We're not at our
No,
level.
we're not.
I don't think we are, but you're absolutely right. There's a lot of it around. And I think the misconception is even if every single specialist, medical, surgical, cardiology, everyone else was to deal with obesity exclusively, there are still not enough of us to treat it, which is why there's a push worldwide to try and move this over to primary care so that there are more people involved. But even then, I do think you're right, Wendy. We need to play nicely because otherwise it will become a bit of a problem with the internal squabbling really not doing people living with obesity much good. There's enough stigma without that.
So do you think surgeons should be learning about the medications as well? Like, do you prescribe medications, Carol?
Yes, but mostly to patients who did bariatric surgery, like primary medication, usually with the endocrinologists. But if the patient had surgery before, they go on with the follow-up with the surgeon. So I'm okay with prescribing medications for that population, but not primary treatment. I know a lot of surgeons do it, but it's like my personal option.
Fair enough. Sorry, I didn't mean to interrupt you.
No, I was going to ask you the same question. Are you happy prescribing?
I'm becoming happier. I predominantly, like Carol, will do the post-operative, but the pre-operative, particularly complex patients, I'm lucky enough to work in a multidisciplinary team, and I sort of bow to the better expertise of our obesity specialists, endocrinologists, and physicians. But I'm learning a lot, and I'm enjoying learning a lot from working with people. Yeah.
Amazing. So we're very lucky. We've got 4 metabolic bariatric surgeons in our team. We have a really large multidisciplinary team, over 30 individuals. And I would say I'm very happy for all of us to share the load, because it is a huge load. But I will also recommend for people who are perhaps in private clinics and on their own that there's a whole new field of nutrition around GLP-1s, psychology support around GLP-1. So it's not just who prescribes, it's what support structure do you have around it. Very similar to metabolic bariatric surgery, which is a bit more advanced in that field. But I think, that's the next watch this space. What do we need as a skeletal structure around prescription of GLP-1s? Just like there are non-responders, there are about 5% of people who are hyper responders, whom you will start on the lowest dose and they will appear a month later having lost 15 kilograms. But they do not get the dietary support that people with metabolic bariatric surgery do. They don't get the vitamin supplements they do. So I think just watching that space. But the more people prescribe, the more they get a feel for what's going on.
How closely do you think we need to monitor things like body composition in people on OMMs?
So that's an excellent question. Within our centre, we do it every 3 months, unless someone is a hyper responder, in which case we do it a little bit earlier. And we only do in-body or bioelectrical impedance within a clinical setting rather than a research setting. But it's really helpful. It's really helpful for us to understand how they're responding. It's really helpful for patients because it encourages the extra protein intake. It encourages them to exercise more. I think it has been an eye-opener for us as well as for patients. We don't do it so frequently, interestingly, after metabolic bariatric surgery. We tend to do it at 3 months and then every year. Whereas with GLP-1s, because we're learning, we're doing it a bit more frequently.
Because that's the fear, isn't it?
There's another question from the audience saying that I heard one of the experts mention that only 1% of people who could benefit from surgery actually have it. How do you think we as a society can help present information and to the public, promoting understanding of benefits of surgery, and as that is the gold standard?
I think, I don't know the answer to that. I think making it accessible. I think IFSO, I know, is doing some campaigns using social media, trying to destigmatize and demystify surgery. But yeah, we've never been hugely successful at doing that. I don't know, Carol, you're young and smarter than me, I think, at these things. What do you think?
I think that's not a problem only regarding the public. For example, here in Brazil, we have a lot of problems with access to treatment. It's not the public. Even if the patient wants, in public health system, we don't have surgery in every city. We don't have surgery in every, even tertiary hospitals. We don't have bariatric surgery in every hospital. There is a lot of demand from patients, and sometimes we cannot give surgery to everyone who needs. So it's not, the question was like, if people don't know they need surgery, but actually even the patients who need surgery, whose medical treatment engage them with surgery, they don't have access. So I think our biggest problem is access to treatment and how to train more surgeons, how to make it available with minimally invasive treatment. We know that's very different around the world, of course, but the countries that have higher rates of obesity have lower rates of access to bariatric surgery. So I think we have to work also a lot of on that aspect, and it takes political conversations with public health and money talks with governors and all that stuff. That's very difficult for us as surgeons to do.
I think reducing stigma is really central to that, though, as well. I totally agree with everything you said. And if you take the analogy of depression, 20 years ago, people with depression were told just to get over it, whereas now we recognise it's a disease and that there's multiple treatments. And it took a number of high-profile people coming out and saying that they'd struggled with it, and that enabled people to connect and empathise. And once you empathise with someone, then you're more likely to want to help them. And that's the sort of public empathy piece that I think has been hard to find. But I do think things are changing. And again, I think the medications have helped that conversation because people start to see the power of weight loss, if not for themselves and their family and friends.
Yes, totally agree. Our time is coming to an end, but I would like to discuss another statement that caught my attention regarding patients should have medication or endoscopic therapy before revisional, always before revisional surgery. What are your thoughts on that? Do you agree? Do you disagree? In which situation? I think that's also a very hot topic to discuss.
So shall I start with that? I have very little expertise with endoscopic surgery, but I can comment on medication. I think because there are hyper responders and because a person has already had one surgery, our practice here, unless it is a structural problem, is to go for obesity management medications as second line before revisional surgery. And that's done unanimously. We don't.
And I would tend to agree, if you're doing the revisional surgery for a weight indication, then, trying a medication's probably a good idea. But if you need it for GERD or for some other, side effect of the surgery, then probably giving people gastroparesis isn't such a great idea. But never say, I don't think in medicine we can use a universal statement very often, but in principle, if the patient's open to it, it's probably a good starting point for weight-related patients.
Yes, that's exactly what I was expecting you to answer, because I think we need to address the structural problems, the anatomical problems, and the complications, because I also agree that we should, if it's focused on weight, we should try medication and even endoscopic therapies when available. But I think patients and some doctors, not bariatric surgeons, go straight to the medication without investigating the anatomical problems. I think we should look for GERD and structural problems before starting the medication, because as Wendy mentioned, we don't want to give gastroparesis to someone already with a lot of GERD. So I also believe that some patients had poor side effects because they had anatomical problems and started to have medications and got worse symptoms and worse quality of life. So I brought this question exactly to highlight the importance of investigating anatomy and GERD and all these kind of complications that we can have after surgery.
There's one quick question by Andrew Curry, who's in the UK, saying, should we use bile acids, ursodeoxycholic acid with GLP-1s? That's in exactly the same bucket as do we need to use multivitamins with GLP-1s. And you're right, we do see biliary disease in people who lose weight very quickly for any reason. So we use it for 6 months following metabolic bariatric surgery, and it is that's a study waiting to be done. So if you're keen for something to do, that sounds like a great plan. Particularly for the high. Yeah. Brilliant.
Oh dear.
So I think our time's up. Thank you very much, Carol, for an excellent session. Thank you, Wendy, for some fantastic insights. And thank you to both IFSO and BJS Academy for giving us the opportunity to discuss this really important topic. Have a lovely evening, morning, afternoon, wherever you are.
Thank you. It was great.
Thank you. Thank you so much, Carol. Thank you, Sarah.